my name is Monica Bailey. I'm currently a Doctor of Nursing Practice student at Colorado State University of Pueblo, and I am going to talk today about why I believe we should be doing routine obstructive sleep apnea screenings in all adult patients in the primary care setting. So I do have a personal connection to this. I was recently diagnosed with obstructive sleep apnea, but my provider was not the one to bring it up to me. It was actually the other way around. And I feel that many people that don't have the medical background that I do would not have the wherewithal necessarily to bring this up. And it's a very dangerous disorder that, if left untreated, leads to a lot of chronic health issues and overall can end your life early. So I think it's very important that we be addressing it in preventative care rather than waiting till tertiary care when people are admitted to the hospital. So this leads me into my PICO question, which is, in primary care patients, would a routine clinical screening tool for obstructive sleep apnea risk, abbreviated to OSA, as opposed to only screening the symptomatic patients, lead to an increased rate of diagnosis and treatment of OSA patients? Currently, the United States Preventive Services Task Force, or the USPSTF, a federal governing body that gives official recommendations on preventative care in America, do not recommend routine screening of OSA for reasons that I will go into in a little bit. They do not have any standardized protocol, so therefore there is really no standardized protocol in primary care for screening obstructive sleep apnea, and therefore they do recommend that providers use their clinical judgment, which can be effective, but I will give an example where it was not effective and it had a big impact on a patient because of that. So what makes this a public health crisis? Why should we be really concerned about this? Well, there's a study out there that shows that about 80 to 90% of obstructive sleep apnea sufferers are undiagnosed and therefore untreated. Left untreated, this disease can cause a lot of cardiac, neurologic, and quality of life complications. Cardiac-wise, it can cause hypertension, pulmonary hypertension, increases all-cause mortality, can cause heart attacks, and on the neurologic front, it can cause cognitive decline and stroke. It can also have things as simple as quality of life, which we all know is not that simple, and really can affect your day-to-day. It can cause daytime sleepiness, dry mouth, headaches, primarily headaches right after you wake up because you were hypoxic in the night, depression. It has decreased productivity to the level that it can actually really affect your ability to be a functioning human and go to work and enjoy your free time, and I'll go into that a little bit more in my case study. And it will actually increase your risk of motor vehicle crashes. So this is most likely to affect men, but it does affect postmenopausal women as well. High BMI, especially greater than 35, is significant. However, a study found that if you had a BMI greater than 30, that about 20% of the population has or is projected to have obstructive sleep apnea, as opposed to only 3% of the population of regular BMI, which would be 18.5 to 24.9, as opposed to above 30. So it does significantly tie in with your weight, but that is not the only risk factor. Also, those with Hispanic, Black, or Native American ethnicities are at high risk. In the other group, this is more rare, but you can see with certain mouth and throat anatomy. So if you look at my diagram on the left here, you will see exactly what really happens in sleep apnea. The muscles in your mouth and your oropharynx relax in your throat, and it causes this blockage of the airway. So you could see if you did have certain mouth and throat anatomy, you would have more of an issue, which is why a lot of people that are overweight suffer with this, because you tend to have more adipose tissue in your neck. So it has more pressure and less space on that airway, and it's very easy for it to close as opposed to someone of a normal weight. So my case study addresses a 62-year-old female patient going into primary care. She has a 28-year history of being overweight or obese, so roughly half of her life. However, she has never been recommended to have a polysomnography or sleep study by her provider. In the past 5 years, she has developed high blood pressure, high triglycerides, hyperlipidemia, and aortic insufficiency. In about the past 2 years, she has developed diabetes mellitus type 2. However, she has had chronic fatigue and daytime headaches for decades, and she has voiced this to her provider, but due to lack of standard protocol in our primary care setting, the provider never recommended polysomnography. Because of that, the patient, who should have potentially been screened 28 years ago, is now suffering with many comorbidities that could have been potentiated by the presence of obstructive sleep apnea. She has since been diagnosed and treated with CPAP, which has greatly improved her quality of life. This case is near and dear to my heart because the patient that I'm describing is actually my mother. And the reason I chose to do this project is when I was diagnosed with obstructive sleep apnea, her and I began talking about how neither of our providers had brought it up. Not to single out any provider, this is a systemic issue, that providers are not bringing this up to patients for whatever reason. I don't know if it's because we're worried about offending patients and their weight, or if it's just a lack of understanding about the complexity of this disease. But we really do, as providers, need to be addressing this when people first show risk factors and not waiting for them to have the lifelong issues that can develop from having this disease. So after my mom and I discussed this, and I really thought, wow, I should do a little project on this. I should look into this. This is something that's significant, and if I could help someone in the future to avoid getting hypertension and diabetes and all these other things by getting diagnosed and treated for their sleep apnea, then I should try to do that. So to do that, I'd have to launch a search via a PICO question, because this is quality improvement and not research. Those are two very different things. Quality improvement looks at the existing literature using a PICO question and looks to improve on our current practices. So with that, a PICO question breaks down to P, or population, I, intervention, C, comparison, which is often the way things are being done already, is the comparison, outcome, and sometimes time. You do not always need time. That is an optional part of the question. Depending on your project, it becomes more or less important. So the point of a PICO question is to create a very refined and accurate search, so that when you look into this topic, you find the information you need and not a broad array of information. Because there's so much information out there on the internet and in libraries that if you just go in blind, you're never going to find what you need. You need something to be very tailored. You need to see, pertaining to this exact situation, what are people doing right now? So looping that back to my case study, I look at and say, could an obstructive sleep apnea clinical screening tool, which would be the intervention, have helped the patient in my case study, my mother, population, to be diagnosed and treated decades ago, which would have been an outcome, as opposed to her current comorbidities and complications, which is the comparison. So using that, I can launch an extensive literature review. So looping back to the USPSTF guidelines, they currently only recommend screening symptomatic patients. Their reasoning for this is the lack of understanding and research of screening in mild and moderate risk or asymptomatic patients. So they recommend that we do more research in these areas. Also, their official statement says that the perceived risks outweigh the benefit. However, these risks they're referring to are all more eye, nose, throat based. So their ear or eye, nose, and throat complications from CPAP or mandibular adjustment device use, which would be fitted by a dentist. These can result in dryness of the airways and nasal passages, pressure injuries to the face, and pain. So in my literature review, I found that the most widely used screening tool is Stop Bang. I want to preface this with all of these are risk tools. The only true way to diagnose sleep apnea is to do a sleep study or polysomnography. So the Stop Bang is simply an acronym. It's 8 questions, and every time you answer a question with yes, that is a point. So low risk on this exam would be 0 to 2, moderate would be 3 or 4, and high is 5 or above. Now, if you score 5 or above on this, there's a high correlation, high accuracy that you will be diagnosed with obstructive sleep apnea if you go on to have a sleep study. There is more false positives in the low and moderate risk categories, which I think is where the USPSTF gets kind of hung up. However, the current studies have showed that if you're in the lower moderate risk categories, you want to focus more on that bang section. And if that includes BMI, age, neck circumference, and gender. And if you had more positive answers in that section, there's a good chance that even though you scored low or moderate, that you might have obstructive sleep apnea and really should get screened and tested. So in my literature review, there was 4 studies in particular that I thought fit close enough to the quality improvement study I'm trying to implement as a case to make why I should implement that. So the Sony 2023 study was held in New Jersey at a primary care family practice. It not only screened patients with the typical risk factors, they screened people with high blood pressure and obesity as well, even if they were asymptomatic, and they used the stop bang. Actually, all of these studies used the stop bang. It ended up being a level 6 because it's a quality improvement study and not a systematic review or anything like that. But of the 100 patients that were involved in this study, 88 of the patients scored moderate or high risk, and 36 patients were referred to sleep medicine for testing. Now, they don't have information on how many of these people were diagnosed, but I think it is significant that there was 36 people referred off that could have potentially been diagnosed and treated that would have not have been otherwise. So the significance of the implications here is when we're looking at that moderate risk population, there is a high level of provider discretion, and it stresses why we need to come up with a protocol, because different providers are going to decide something different. And while our clinical judgment is important, it's good to have a guideline for somebody to fall back on and to really educate providers about what they should be looking for when conducting these screenings. So the next study is Mackey 2022. I thought this was an interesting one because it was an occupational study. So there was 571 Texas state employees that started in the study. However, they only retained 479. So the official sample is 479 because that's the amount that were retained through to the next year, and this was a longitudinal study. So this is a level 4 case series level of evidence, and it's longitudinal, as I said. So they had all moderate and high risk scoring patients, which was 41 patients, were educated about sleep apnea testing. 8 of them were tested, and 4 required prescription of CPAP as treatment. Unfortunately, even though this was a large amount of people, it sounds like a lot of, only a few were diagnosed and treated. However, I applaud them for their effort in trying to broadly, routinely screen every one of their state workers. So the important thing to stress here is these screenings have low fiscal impact. The fiscal impact really doesn't come in until you get to the polysomnography component, and I'll get into that a little later. And workplace organizations can implement this, even if primary care practices didn't want to, as a way to ensure another level of preventative care for their workers. Showalter and O'Keefe, 2019, was a study conducted in a primary care nurse practitioner-led practice in rural Iowa. This was adult patients with high blood pressure, and they just gave everyone that had a high blood pressure diagnosis the stop bang survey, regardless of symptomatic or not. This was level 6 quality improvement project level of evidence. Of the 30 patients who were included in this study, 12 scored high risk and 12 scored medium risk. And every patient who did receive referrals to sleep medicine were diagnosed with obstructive sleep apnea. So I think that's significant because the providers really hit the nail on the head there. They were sending these people, even though the guidelines only say to send symptomatic people. So they were able to diagnose people that would have otherwise been ignored per the current guidelines. The significance here is that we really should be looking into people's comorbidities. And we should potentially add that as another layer of screening when we're looking at the stop bang tool. So my last study that I include is Onanye et al., 2019. This was done in East Houston, Texas, in a primary care practice. They also used the stop bang survey, and they had 187 participants. This was a level 6 quality improvement study and level of evidence. So the rate of screening in the primary care practice increased from 3% to 43% pre and post intervention. The more significant thing, though, was their referral rate increased from 0 to 39. So no one was being referred to sleep medicine for further studies before this. And they were up to 39%. 61% of the study participants had a stop bang score of 3 out of 8 or higher, so moderate or high risk. And 67% of those people were diagnosed with moderate or severe sleep apnea. So pretty significant numbers to see. Obviously, there's not a lot of literature about this out there because it's an understudied area, and I think it's something that every provider that is going to work in primary care should be somewhat vested in. Some limitations of these 4 studies previously mentioned include convenience sampling. That was actually the most widespread one. Convenience sampling was a problem in all of them except Mackey because they screened their own employees and there was no specific criteria for picking them. They just screened everybody. So the problem with convenience sampling is it damages generalizability. So when going about making a QI project out of this, that needs to be considered. As for a study outcome to be considered credible and able to be applied to the general population, you have to make the case that it could be generalizable to the general population. The other limitation I ran into is the Mackey 2022 study had issues with retention of almost 100 employees that they lost. So that can really damage credibility because you say, oh, well, what would the results have been if those 100 people had hung on for a year? And that's the downfall of longitudinal studies. They're helpful. They give you a lot of information, but you have to make sure that the people that you recruit are staying with you for the duration of the study, and that gets harder the longer the study goes on. So with implementation, there is a lot of barriers in quality improvement projects. So recruitment is a big barrier. One way to overcome this is contacting quality improvement leaders at organizations directly and then collaborating with them because they know their organization probably better than you do. Funding and time is important. So I mentioned the time with the longitudinal study could damage the credibility. So I think it's important to keep it on a small scale. So instead of going across to 10 primary care practices, you choose one in small setting. So you have a certain time frame, you have a certain amount of patients, enough to make it statistically significant, but not overload the study. And you stick to that, and then you should have a lower fiscal impact and overcome this barrier. Third barrier is company cultural engagement. And in my opinion, this might be the biggest one, because if people are not on board with the intervention, the people that need to be implementing the intervention, it's not going to work. Even if you want it to, it's not going to work. So another way to overcome that is to adapt to their communication and culture style. So you'd want to assess the environment before you even start implementation. Conflicting values and priorities. This happens a lot, especially with corporate leaders. One way I've found is to find common ground. Why should this be important to them and not just to you? When I worked at a previous employer, I wanted to implement a study on getting rid of rotating shifts in the same week for nurses. Now, this sounded more of a, oh, that's convenient for the staff because they won't have to work night, day in the same week. But I was able to link it back via literature review to patient safety and medication errors. And when I presented this to leadership, the chief nursing officer actually became very concerned because she didn't know that making nurses rotate like that could have such a dangerous impact on patient safety. So I think it's always good to find that key piece, right? Something that matters to them, that will tie it back into them. Why should they care about this? So lack of experience, this is one that's really hard to overcome. I think the important thing is when you're picking a setting for your quality improvement project, you pick one where they've at least seen a project before, because otherwise they're not really going to understand the significance of adhering to the interventions. Management and staff dichotomy, so toxic work environment versus healthy work environment. This is also another one where you're picking a setting, you should really be very careful to pick one with a healthy work environment. But if that's absolutely not attainable, you can do ongoing dialogue, discussion, and input with the bedside staff, because they're really your stakeholders. Those are people that are conducting the study for you, basically. So you should give them input, and you should value that input and adapt as needed. And usually that makes them feel heard, makes them want to participate in the intervention more readily. The last is an unclear explanation of the expectations and the plan. So one way to get over this is to have written meetings, have multiple methods of communication given multiple times without oversaturation, because we all know if something gets thrown in your face too many times, you're going to resent it just out of the fact that you don't want to hear about it anymore. But I think having multiple ways for people to learn that information and explaining it very clearly, when are we starting, when are we ending, what is exactly expected of you and your role, will lead to a better outcome where this could be a facilitator instead of a barrier. So as you can see, there's a lot of barriers. Implementation science is not easy. It's a very complicated thing. And implementation and then sustainability are usually the downfalls of otherwise what would have been a successful quality improvement project. This is why many studies will recommend that doctorate of nursing practice or PhDs conduct these quality improvement projects. However, PhDs are taught to do more research-based questions, whereas DNPs are taught specifically in quality improvement. Unfortunately, DNPs are currently underutilized in their settings due to lack of understanding of this fact. So with any quality improvement project, it's really important to have theoretical frameworks set up that you build your implementation off of. So for my obstructive sleep apnea study, I think that a knowledge to action theoretical framework model would be effective. It's been shown to be effective in implementing other studies in primary care, especially screening tool studies. So Moore 2018 found that the knowledge to action plan's purpose is to inform and lead QI project implementation, basically. It starts with gathering past research to formulate a plan of action for quality improvement. So as I've stated, it would be kind of the literature review that I've reviewed here. You really need to have your implementation plan 100% down before you do implementation. It will be subject to change, but you need to have that roadmap. You cannot go in blind. You can't go in half finished. After that, you would do research collection. Problems / knowledge gaps need to be identified and addressed. And then you would do the following 6 steps and then repeat them as needed. That's why it's a circle. So you want to put it into a local setting. So for me, I would probably find a local Colorado Springs primary care practice, and I would analyze, are they a good fit? Do they have a healthy work environment? Do they have experience with quality improvement implementation? There's a lot of factors that go in there that you would need to tailor your study to that specific environment. After you've done that, you want to identify barriers and catalysts, which is really ties in with putting it in a local setting, because when you're putting it in a local setting, you're going to do study on that facility's culture. The next step would be to take what you know and adapt your interventions and implement them appropriately. After that, you would monitor information use. So this is more monitoring compliance with the intervention. Are the staff doing it? If they're not, why are they not? Are you looking in? Are you having that dialogue with the staff to kind of bridge that gap and to keep your project successful? After that, you would want to assess the outcomes of the project, look for sustainability, and do things that would help to sustain the project. And then you would repeat the cycle as needed. So the thing I really like about this model is it's not one size fits all. You can use it as much as you need until your project is successful. So addressing the other reason that quality improvement projects usually fail is sustainability. Sustainability walks hand in hand with implementation. Usually with good implementation comes good sustainability. But rolling into that, you really should include all stakeholders in all aspects of your study, not just in the beginning, not just during, not just after. So stakeholders for my study would be the providers, it would be the bedside staff like medical assistants or anyone working in that office that could be assisting in giving this screening tool out. It would be the management and leadership, and it should be most APRNs should be concerned about this, and physicians, because this is our patients we're caring for. And this is a huge gap in care that we're letting lapse right now. So another way to maintain sustainability would be to choose the right site. So this goes back to implementation. If you start in a successful place, you're more likely to end in a successful place. You want to get frequent feedback throughout your study. So the same way that you get dialogue before you start your study from all of the stakeholders like the bedside staff, you're going to want to go to them frequently and get feedback, and you're going to want to listen and implement that feedback. That's important. You want to manage expectations. It's not going to be perfect. There is going to be things that go wrong, and you're just going to have to adapt and roll with it if you want to be successful. The biggest barrier here is the psychological aversion to change. We all hate change, just at different levels. It's a psychological human nature thing. We get very used to our routines, and change is harder. So things to overcome that would be to celebrate the small wins, offer frequent encouragement. You need to validate the people involved in this study in the fact that, yes, this is slightly inconvenient for them to be participating in this. It's another chunk out of their day. These people are busy. They work in healthcare. And you need to validate that it can take longer and give them the space they need to accept that change. They're not going to accept it overnight. And that's part of managing your own expectations, that it could take a while for people to adapt. However, if you give them the space and the time and the resources to accept, then the study could be sustainable. And the more sustainable it is, the more that you can argue long term why this should be a generalized quality improvement across all of healthcare. So in our world today of electronic health records, electronic medical records, it's always important to consider technology in your quality improvement. Like many quality improvement projects, the use of an algorithm in the electronic health records, such as Epic. Epic is a great example because they have lots of alerts and algorithms already built in, and it's a software where you can build into your own. So these can be used to create alerts. So if a patient were to come in with certain parameters, say they have a BMI of 37 and high blood pressure, and they complain that they've been sleepy in the daytime, that will automatically trigger, we need to do a stop bang survey, and then trigger the provider. Okay, here was their stop bang survey score. We need to potentially refer this person to sleep medicine for a sleep study or for further workup. Moving back to the fiscal impact, so very obviously, a screening tool is going to have low fiscal impact. The biggest part is going to be that you're taking a chunk out of people's time in the day, but the actual screening tool costs barely anything to implement. The significance, and I think, just in my personal opinion, where you would get pushback with this from insurance, would be the fact that polysomnographies, or sleep studies, cost between $1,000 and $7,000 per patient. The average is about $3,000. It's a pretty significant chunk of change. It's not the most expensive thing in healthcare, but it's not cheap either. and I think that will end up being a barrier long term. Currently, sleep studies are partially covered by Medicare, and there is some state Medicaid programs that cover them, including Massachusetts and California. However, not all state Medicaid programs will cover this. So that could be a barrier all in itself, because a patient's insurance might not cover this, and it might not be a cost that they can afford to yield. So now we come to maybe what is arguably one of the biggest reasons that we should be implementing this study. So Healthy People 2030, one of the goals is to address healthcare inequity and social disparities and to provide solutions. Well, this could be a very simple solution because Eatondale, Soso, and Matos 2021 did a systematic review that found a correlation between low socioeconomic status and increased incidence of obstructive sleep apnea. There's also studies out there that show that people of lower socioeconomic status are more likely to be incompliant with treatment and need more education. So this is a very vulnerable population. And this is a way that if we intervene in the right way and get them treatment and continue to educate them, we could potentially be knocking out one of the biggest healthcare inequities by creating an environment where maybe they don't get hypertension or diabetes down the line, maybe they don't get a heart attack, or maybe they're just much less likely to get those things. So after looking at all of this, my only question is why? Why have we not done the study yet? It looks like there's been a few studies done, but why is there not more investment into something that is clearly a public health crisis, where we could implement something that has a low initial fiscal impact, that would address a major healthcare inequity, and that we could easily use this knowledge to action plan and key points on implementation and sustainability to make a successful QI project. I think that this is a project that could help a lot of people and help the quality of life and the quantity of life, much frankly, too. So that is why I, Monica Bailey, believe that we should conduct a quality improvement project where we routinely screen everybody in the adult primary care setting for obstructive sleep apnea. My references are attached on the next page. Thank you.